the next and the last speaker is Raed Jondi from Canada. He's going to address advance in diabetes and vascular cognitive impairment.
Thank you very much for inviting me. That's a very tough act to follow, Dr. Amarenko. Hopefully today I will just try to raise the specter of vascular cognitive impairment and dementia and diabetes. Some of this has already been very nicely discussed by Dr. Bordet and Dr. Amarenko. So I'll probably be able to skip through a few slides that are overlapping and make this a concise talk. So vascular cognitive impairment, it's an umbrella term. And just to define it before this talk, the two main branches are post-stroke vascular cognitive impairment, or basically without a stroke. And after a stroke, that's typically defined as within the first 6 months. And the risk factors are essentially the same as those that lead to stroke, which are 20% small vessel disease, cerebral small vessel disease, and 80% large artery or cardioembolic. On the other hand, we see VCI without a stroke, and that's typically due to cerebrovascular disease, and it has the reverse association, so 80% small vessel disease and 20% large artery or cardioembolic. Both of these can lead to cognitive impairment without functional loss, or frank dementia where there is a loss of function or activities of daily living. Doesn't need to be said, but there's a large concern for the coming decades for dementia. Now, the age standardized incidence is staying about the same, but the absolute numbers will rise dramatically globally, and that's because of the aging population and basically longevity. So we also have a diabetes epidemic, and we know from the projections that the numbers of individuals with diabetes is also going to rise dramatically, 200 million by 2030. And as I'll show, those with diabetes are at particular risk of cognitive decline and dementia. So this is going to be a main pathway towards dementia in populations. The risk of dementia in those with diabetes is as high as 1 in 10 in those older than 85 years of age. So why is this important? Well, the top title is weird, but this is the NUN study. So this was done in the 90s, and the main finding was that 50% of those who met pathology, so they looked at the brains post-mortem, and 50% of those who met pathology for Alzheimer's disease expressed clinical dementia during life. But if an infarct was present, then it was 93%. So there is some unmasking of cerebrovascular disease or some kind of interaction or co-pathology, such that if there was a stroke, then the risk of dementia during life was much higher. And those with 1 to 2 lacunar infarcts plus Alzheimer's pathology had a 20 times increased risk of dementia during life. And as Dr. Bordet nicely pointed out, we're seeing more and more that the vast majority, the majority of pathological cases of dementia are actually due to mixed pathology. So while Alzheimer's disease is thought to be the most common cause of dementia, from a pathological point of view, more commonly we're seeing mixed, which is a mixture of Alzheimer's pathology, amyloid beta pathology, and vascular pathology. So this really has to be paid attention to. We know that risk factors in midlife are associated with dementia later in life, and this study from the ERIC cohort shows the hazard ratio for midlife diabetes of 1.77 for dementia. That is higher than hypertension, smoking, obesity, and education, and only somewhat lower than ApoE4, which is the main genetic risk factor for dementia. Meta-analyses have shown across observational studies that those with diabetes are at higher risk of dementia, both vascular dementia as well as non-vascular dementia. And that seems to be also related to glucose levels, actually independent of a diagnosis of dementia. Those without diabetes or with diabetes, looks like higher glucose levels, average over 3 months, are associated with a higher risk of dementia. That's confirmed in meta-analyses as well. This is across the spectrum of diabetes. So those with pre-diabetes have a higher risk of vascular dementia than those without diabetes, and those with diabetes, the risk is, of course, magnified. Not only do patients with diabetes have a high risk of dementia, but also subclinical cognitive decline. So in the UK Biobank and many other studies, there's obviously cognitive decline in multiple domains, including executive function and memory, and that's been mentioned already by Dr. Bourdet. And this meta-analysis shows subclinical cognitive impairment in executive function, memory, attention, language, and so on in people with diabetes. And subclinical cognitive impairment can occur decades before dementia. So it's quite an early marker of risk. The Lancet Commission for Dementia has identified diabetes as one of 12 main risk factors for dementia. Here, the prevalence in the data set was 6.4%, and so the population attributable risk is somewhat lower at 1%. However, it is higher than obesity, alcohol, and it does depend on the population that you study because of the prevalence being quite important in the calculation of PAF. And you see that here in a US multi-ethnic cohort, the diabetes population attributable fraction is about 7%, and it's higher than air pollution, social isolation, depression, smoking, brain injury, hearing loss, and less education, all of which are important factors for dementia. So it puts that in some perspective. And it's only slightly lower than hypertension. It also depends on age. So the earlier that diabetes is diagnosed, the higher the hazard of dementia. So the 1.21 is basically within 5 years of 70 years old. The 1.61 is 6 to 10 years prior, and 2.32 is over 10 years prior. So the hazard increases linearly with younger age. So vascular injury is the hallmark of vascular cognitive impairment, particularly in diabetes. And these are the two main manifestations, but there is significant overlap. On the left, lacunar infarct, so deep subcortical infarcts in the brain. Really one of the main risk factors for that is diabetes. And on the right, you see whole brain dysfunction, white matter hyperintensities as a result of chronic ischemia. And diabetes increases the risk in the Alliance cohort, which is a cohort of people in Canada with MRI scans, increases the risk of both lacunar infarcts and white matter hyperintensities. And these have been recognized in diabetes for quite some time. The most studied I've already mentioned, so infarcts and white matter hyperintensities, also brain atrophy, which I will mention later. Less studied have been microbleeds and possibly microinfarcts, because you need a very high resolution MRI to detect that, but really brain pathology across the spectrum. Dr. Emrenko mentioned interstroke. So stroke is a very strong risk factor for dementia, and diabetes being a risk factor for stroke, clearly that's going to be one of the main ways that individuals with diabetes develop dementia. It is a strong risk factor for stroke with a hazard ratio of 1.36 in interstroke. And what we're seeing, of course, this is well recognized, at least in the West, is increase in the rates of diabetes over time. So this was a population-based sample in Canada, and we see increases in diabetes throughout all age groups. But interestingly, if diabetes is present at younger age, there's a much higher hazard of stroke. So you can see a linear increase from 80 years old, which is relatively modest, to 30 to 39 years old, which is a hazard ratio of close to 8 for developing stroke over a median of 5 years. This is the same figure that's already been shown by Dr. Bourdet. I will not belabor that point. The importance of stroke is that there is a cognitive decline afterwards. Some of it's acute, and the remainder of it may be chronic and degenerative. So diabetes is really a main factor in post-stroke cognitive impairment. After stroke, about 1/2 at 1 year have cognitive impairment, and 1/5 have dementia, and those with severe stroke is 1/3. And diabetes comes right after age, education, pre-stroke disability, which are really obvious markers of cognitive impairment. It comes right after that and prior to any of the other vascular risk factors. That didn't show up at all, so basically just showing that diabetes is associated with cognitive impairment in all domains after stroke, but this study has already been highlighted. So is it possible that by addressing diabetes and vascular risk, we can actually reduce dementia in the population? Certainly it's been postulated, and there have been some concurrent declines in both stroke and dementia, at least in Canada, which raises the possibility that we can address both at the same time by improving vascular risk. So I'll switch gears here to talk about some newer therapies in diabetes that have promise for vascular cognitive impairment and dementia. I'll just briefly mention that metformin, sulfonylureas, and DPP-4 inhibitors have not shown a significant association with reductions in vascular cognitive impairment or dementia. So then I can move on to GLP-1 receptor agonists. So already shown that there is a robust effect on stroke risk reduction for GLP-1. And the REWIND trial actually measured cognition throughout the course of the trial. It was close to 10,000 patients with type 2 diabetes and additional risk factors. And there was a reduction in stroke risk, we know that. And for cognition, they looked at two tests, the MoCA, which is a measure of global cognition, and the DSST, which is executive function and processing speed, and looked at whether there was a reduction in 1.5 standard deviations from baseline, which was a marker of cognitive decline and a pretty standard threshold that's used. Close to 9,000 people had follow-up, and they found that for dulaglutide there was a reduction in cognitive impairment in follow-up by about 14%. So that's quite striking. Really finding anything for cognitive impairment is exciting. And here they included stroke as a time-varying covariate as well, and it did not attenuate the association, which means that this was not mediated by stroke. Meta-analyses of observational data have suggested that GLP-1 receptor antagonists can reduce the incidence of dementia compared to individuals with diabetes not on these medications, and that's not the case for insulin, sulfonylureas, and DPP-4 inhibitors. Taking this, of course, with a huge grain of salt because it is observational data. There are actually some interest in using semaglutide for early Alzheimer's disease now. Why is this the case? It does not seem to be mediated through stroke, does not seem to be mediated through glycemic control, so raises the possibility of many other mechanisms. And GLP-1 analogs are known to reduce inflammation, oxidative stress, and may have some neuroprotective effects that may result in improved cognition and memory. SGLT2 inhibitors, while this was not measured in a randomized clinical trial, there are observational data sets which have now shown a reduction in long-term dementia. This is from Ontario, Canada, and a matched study comparing those with SGLT2 inhibitors to DPP-4 inhibitors. Everyone here had type 2 diabetes, of course, and they found that dapagliflozin and empagliflozin were associated with a lower risk of all-cause dementia, but not canagliflozin. Again, observational data set, but intriguing nonetheless. And similarly in Taiwan, a large study showing a reduction in dementia on SGLT2 inhibitors. So we have meta-analyses now showing an effect of SGLT2 inhibitors on dementia. GLP-1 receptor antagonists, borderline, but not significant here. And certainly we can think about, postulate, come up with many possible mechanisms why these medications might be neuroprotective. At the end of the day, we don't know, but there are robust reductions in inflammation which are known to be associated with cognitive impairment, increases in BDNF, it's a neurotrophic factor, and maybe really just improvement in vascular risk overall and reduction in weight as possible mechanisms here. But just intriguing that we're seeing this in SGLT2 inhibitors actually without a reduction in stroke risk, so it means that there must be other mechanisms at play. Inflammation, really one of the main themes during the last 2 days. Possible that these two classes of medication are acting on the inflammatory cascade and reducing IL-1 beta and inflammasome activation, M1 polarization, and systemic inflammation. And in type 2 diabetes, the blood-brain barrier is quite leaky, so reducing inflammation systemically may be quite beneficial. There is a higher degree of inflammation systemically in type 2 diabetes, but more interestingly, in those with cognitive impairment, they in fact have higher inflammation overall compared to those without cognitive impairment and type 2 diabetes. Last, I want to touch on the idea of neurodegeneration. So in another potential mechanism of cognitive impairment and a pathway that is potentially modifiable. So in type 2 diabetes, there is a lower cortical thickness, even without cognitive impairment. And that's also seen with cognitive impairment and with dementia. So generally, brain volumes are lower, and cortical thickness is less, which has direct effects on cognition. And the longer that diabetes is present, so over 10 years in the red line, the lower the gray matter volume compared to those who have had it for 0 to 9 years, or those who do not have type 2 diabetes. So some studies have tried to look at all these factors together in very complex mediation analyses, which are limited by their very nature, but help us try to understand if diabetes has a direct effect on cognitive impairment or if it's through these mediators that we've already mentioned. The main two categories being cerebrovascular disease or neurodegeneration. This study found that, in fact, it was mediated through both cerebrovascular disease and neurodegenerative pathology, but there was no direct effect of diabetes on the brain itself. And subsequent studies have essentially confirmed the importance of neurodegeneration. Here it looks like neurodegeneration is the main mediating factor towards cognitive impairment in diabetes. And small vessel disease is not, once you include neurodegeneration in the model, which is interesting that it may in fact be the final common pathway towards cognitive impairment. So quite a complex set of considerations in patients with type 2 diabetes. Certainly starts very early with factors that predispose to cognitive impairment or to resilience, like physical activity, socioeconomic status, and social networks. Diabetes itself, there are many associated factors that may impact the brain deleteriously: vascular risk factors, subclinical atherosclerosis, or macrovascular disease. All of this can result in micro or macrovascular brain injury. And then there are other knockoff effects such as hyperglycemia, glucotoxicity, oxidative stress, and inflammation, possibly amyloid beta pathology, which can affect the brain, leading to neurodegeneration and dementia. Just a few brief considerations before finishing off. Depression is a very prevalent comorbidity in dementia, and depression is certainly linked to cognitive impairment and should be addressed. Hypoglycemia in some studies, although inconsistently, is related to cognitive impairment, but these patients are particularly prone. Concomitant vascular risk factors, so even in patients with diabetes on statins, being in the highest 2 quintiles of LDL raises the risk of dementia. So thinking about that and residual risk. And the fact that when a patient is cognitively impaired, they will be less able to manage their own self-care, and that leads to a vicious cycle where this can worsen. And I didn't talk about physical activity, but there is some evidence that this can slow cognitive decline. This is a risk score calculator, which is not really meant for clinical use, but more to risk stratify patients for clinical trials. And you can see that the risk goes from 5% to 73%. And the main factors here are age, micro and macrovascular complications, depression, and diabetic foot, as well as education. So in a 74-year-old, say with cerebrovascular disease, then the risk of dementia over the next 10 years is about 40%. So in summary, diabetes does increase the risk independently of cognitive decline, and so preventing and treating diabetes may in fact reduce the incidence of cognitive impairment and dementia. There are many other possible mechanisms like metabolic, vascular, inflammatory, and neurodegenerative. We have some possible new therapeutics that are having effects on the brain to reduce dementia. We don't really know why yet, but it's exciting. GLP-1 receptor agonist, SGLT2 inhibitors. Dr. Amarenko talked about some of the similar mechanisms of PPAR alpha, and so whether we basically have on our hands some new classes of brain drugs, I think brain health drugs is quite exciting. So I think it's warranted to include cognitive endpoints in trials of cardiovascular disease, so vascular cognitive impairment and dementia, but also to design trials to specifically look at this endpoint and really think about cognitive impairment and dementia in the overall package of residual risk. Thank you very much.